Bismillahirrahmanirrahim. In the name of Allah, who is Rahman Rahim. Today we are discussing the cystic disease of the kidney because, as you know, there are various cysts which can occur in the kidney: simple cysts, solitary cysts, or multiple cysts, or genetic related cystic disease that are called autosomal dominant polycystic kidney disease and autosomal recessive, and there are some cysts which are associated due to other problems. So I want to discuss today cystic disease of the kidney. Before discussing the cystic disease of the kidney, we should know what is a cyst. Basically, cyst, it is the collection of the fluid and that is present in the sac, and it is lined by the epithelium. This cyst basically arises from the dilatation in any part of the nephron or from the collecting system. So this is called cyst. So coming the cystic disease of the kidney, there are the various cystic disease of the kidney: multicystic renal dysplasia, that is due to malformation and associated with the cystic disease, in which enlargement of the kidney occur. Polycystic kidney disease is very important because poly means more than two or three cysts. In unilateral or bilateral kidneys, there are two types of the polycystic kidney diseases: autosomal dominant polycystic disease, that is called ADPKD, it occurs in the adult life, and autosomal recessive polycystic disease, it usually occurs in the childhood or in the infant. Third type is the medullary cystic kidney diseases, medullary sponge kidney disease, and nephronophthosis. There are some cysts which are related to the acquired. Some patients who are on the long-term dialysis, duration is more than 10 years, then in these patients, cysts can develop in the kidney, that is called dialysis-related cyst. Hydatid cyst, tuberculosis, and neoplasm. So these are the causes of acquired cystic kidney diseases. Cysts can be cortical cyst, that is simple cyst, it is localized, or it is due to hereditary malformation syndrome, tuberous sclerosis, or von Hippel-Lindau syndrome. Glomulocystic disease or extraparenchymal renal cyst, that is pilocalyceal cyst, Haller lymphatic cyst. So coming to the important type of the cyst, that is called ADPKD, autosomal dominant polycystic kidney disease, or adult polycystic kidney disease. So it's congenital disorder and autosomal dominant. It is one of the common inherited genetic disease. If you see the prevalence of this polycystic kidney disease, that is autosomal dominant, 0.1% in the general population, and one of every 400 to 1000 live births. This disease is 10 times more common than sickle cell disease, and it's 15 times more common than cystic fibrosis. This autosomal dominant polycystic kidney disease is a multisystemic disorder and that is characterized by multiple bilateral renal cysts that are associated with the cysts in other organs such as liver. 40% of the cyst can occur in the hepatic cyst, pancreatic cyst, arachnoid membrane, or seminal vesicles. Sometimes non-cystic or extrarenal manifestation of autosomal dominant polycystic kidney disease can occur. Cardiac manifestation, mitral valve prolapse, and in the CNS, berry aneurysm or intracranial aneurysm, 10%. So patient sometimes can present with a stroke and CVA and hernias, abdominal hernias. This cyst formation may start in the intrauterine life or just after the birth. 5% of the nephron affected, or it may involve any part of the nephron. Now coming to the genetic of this polycystic kidney disease, there are two types of gene, PKD1 and PKD2 gene. PKD1 gene are on chromosome 16 and PKD2 genes are on chromosome 4. The PKD1 present early, and this PKD1 has got the rapid course, while due to PKD2 is milder, and these patients can present in the later stage of life. The gene product, that is polycystin, play an important role in controlling the cell proliferation and differentiation of the this cyst formation. Genetic. This slide shows the difference between PKD1 and PKD2. If you see, the mutation is more common in PKD1, 85%, and 15% PKD2. That is why the severe form and early presentation of the PKD1. Onset of end-stage renal disease, sometime even in the adult stage of life or more than 50, and PKD2 near to 70. Problem of the functional is the receptor problem in the PKD1, and in PKD2 is the calcium channel problem. Usually arise from the distal nephron PKD1, and PKD2 can occur all parts, even extrarenal. So PKD1 has got severe form and PKD2 has got milder form. Now coming the clinical features or manifestation, clinical manifestation. Clinical manifestation are divided into renal manifestations and extrarenal manifestation. If you talk on the renal manifestations, so renal size increase with the age, so kidney will enlarge even in 100% of patients with autosomal dominant polycystic kidney disease. It can lead to compression of the local structure like inferior vena cava or digestive system. Common manifestation is pain. These patients can present with a dull flank pain. Sometimes these patients can present with hematuria and cyst hemorrhage that can occur in the 40% of the autosomal dominant polycystic kidney disease cases. UTI is common in these patients. The common organism that leads to UTI are E. coli, Klebsiella, Proteus, Enterobacteria. So these organisms can cause the urinary tract infection. So we should choose that antibiotic which has got penetrating capacity, penetration of the cyst. Nephrolithiasis. Nephrolithiasis are stone formation that occur in the 20% of patients. The type of stones, uric acid stone and calcium oxalate stone, may occur in the polycystic kidney disease. Hypertension is also common in these patients because hypertension occurs in polycystic kidney either due to increased this erythropoietin hormone due to renal mass size increases, so more erythropoiesis and initially hematocrit increase, hemoglobin increase. If hematocrit increases, the viscosity of blood increases. If the viscosity of the blood increases, peripheral vascular resistance increases, so blood pressure increases. As you know, blood pressure is defined as cardiac output multiplied by peripheral resistance. One mechanism is that due to increased viscosity. Second is due to renin-angiotensin mechanism is activated that leads to cyst formation, hypertension. End-stage renal disease. At the end, patient can develop end-stage renal disease in the fifth and sixth decade of the life. If you see the glomerular filtration rate, the decline in polycystic kidney 4.4 to 5.9 ml per minute per year. So what are the risk factors or the bad prognostic factors in polycystic kidney? Male patient, black race, diagnosis and first episode of hematuria before the age of 30, hypertension before the age of 35, hyperlipidemia, low HDL or sickle cell triad. This slide taken from the comprehensive book of the nephrology. It is same already discussed with you, renal manifestation of the autosomal dominant polycystic kidney disease, functional manifestation, concentration defect, reduced renal blood flow, hypertension can occur in these patients, target organ damage, cardiac, cerebrovascular. So this is already discussed with you. Now the clinical manifestation, renal manifestation and extrarenal manifestation. The extrarenal manifestation are polycystic liver disease that occur in the 40% of the cases. It occurs in the both PKD1 and PKD2 that leads to hepatomegaly but preserved hepatic parenchyma and liver function. Pancreatic cyst may occur, ovarian cyst may occur, cardiovascular manifestation, mitral valve prolapse and vascular aneurysm or barrianeurysm 10%. So these patients can present with a stroke or CVA, colonic diverticula. This slide shows the cause of death or mortality in the polycystic kidney disease, why these patients die. If you see the 40% major contribution of the cause of death is the hypertension, heart disease, coronary, cardiac cause or hypertension, heart disease. After that 25% is infection, sepsis, 15% is the rupture barrianeurysm and 20% are other causes. Now coming to the diagnosis. Diagnosis is very simple by doing the renal ultrasound. The renal ultrasound used for the pre-symptomatic testing because of the cost and safety. It is very convenient and safe. So revised criteria have been proposed to improve the diagnostic performance of ultrasound in autosomal dominant polycystic kidney disease. Genetic testing is important also. That can be performed when precise diagnosis is needed. and results of imaging are indeterminate. These genetic tests done by either linkage analysis or molecular testing by direct DNA sequencing, and about in the 90% of the patient it is beneficial. So this slide shows the ultrasound criteria for the diagnosis of the autosomal dominant polycystic kidney disease. It depends upon the age and regarding the criteria of the cyst. In PKD1, if you see age 15 to 29, it should be more than 2 cysts unilateral or bilateral. This PPV is positive predictive value, NPV is the negative predictive value. So 30 to 39, more than 2 cysts in each kidney. So as age advances, the cyst formation increases. Initially unilateral, then bilateral. After that, differential diagnosis of the polycystic kidney disease. Obviously, in case of the polycystic kidney, enlargement of the kidney takes place. So we should think the causes of the enlarged kidney. The common causes of the enlarged kidney. One is renal hydronephrosis due to obstruction. Whatever the cause of obstruction, either stone, either mass that cause obstruction, or malignancy, or due to compressions. Then autosomal recessive PKD, tuberous sclerosis, renal cyst and diabetes. Then medullary sponge kidney, simple renal cyst, and hemodialysis associated acquired cyst. Now is treatment is symptomatic. It depends upon the presentation of the patient. Most of the patient can present in the outdoor OPD clinics. They can present with the pain and urinary tract symptom and sometimes hematuria or hypertension. So if they can present with pain, first we should give the reassurance to the patient, because if the patient see the ultrasound or ultrasonologist tell him, okay, you have got cyst in the kidney, the patient become worried and he become anxious, and then come to us in the OPD regarding these problems. So we should give the first reassurance, because this is a benign disease. It can run, it has got prolonged course. So for the relief of the pain, we should give the analgesic and non-steroidal and anti-inflammatory drug. But remember, we should not use a prolonged period, because these drugs are nephrotoxic. When conservative measures fails or pain doesn't subside, we must think this cyst may be enlarged. So we should do the cyst decompression, cyst aspiration. This procedure should be done under ultrasound or CT guidance. Sometimes the cyst may occur. So to prevent the reaccumulation of the cyst fluid, sclerosing agents such as 95% of the ethanol or acidic solution of minocycline are commonly used to prevent the reaccumulation of the cyst fluid. If multiple cysts are contributing to pain, laparoscopic or surgical cyst fenestration procedure may be beneficial. Surgical decompression is effective in 80% of the patient, 80 to 90% patient at 1 year, and 62 to 77%. If these patients can present with the cyst hemorrhage, so episode of cyst hemorrhage are self-limited, again reassurance is very important. It responds to conservative treatment, bed rest, analgesic, and hydration. If clot, we should prevent the clot by doing the irrigation. This requires some time, require the hospitalization if their cyst hemorrhage continue. Patient can drop the hemoglobin. So we should check the hematocrit and HB. If it is low, we should transfuse the blood. Urinary tract and cyst infections, therapeutic agents of choice include: first, we should send the urine culture or aspiration of the cyst fluid for culture and sensitivity, blood culture. Then drugs should be started. These fluoroquinolone, trimethoprim, sulfamethoxazole. If fever persists after 1 to 2 weeks of appropriate antimicrobial therapy, then percutaneous or surgical drainage of an infected cyst should be done. Regarding the stone, already told you uric acid stone is common in these patients. So potassium citrate is the treatment of choice in these stone forming condition, uric acid stones. And also we should ask the patient he should take the citrus fruits or citrate containing diet. Hypertension, control of hypertension is essential because uncontrolled hypertension accelerates the decline in renal function and aggravate the extra complications. The choice of antihypertensive agents and optimal blood pressure target in autosomal dominant polycystic has not been proved, but we should give the ACE inhibitor and angiotensin converting enzyme inhibitors or angiotensin receptor blocker. These are the drug of choice in the control for the control of the blood pressure if the renal function is normal. If these patient can present with the end-stage renal disease and blood pressure uncontrolled, then we should give the calcium channel blocker, alpha receptor blocking drugs, or vasodilators. These patients can develop progressive renal failure, intracranial aneurysm. So if the size increases, surgery is indicated in intracranial aneurysm. Definitive management of aneurysm between 6 to 9 millimeter depend upon size. If it is between 6 and 9 mm, remain controversial, but surgical intervention is usually indicated for all unruptured aneurysm in which size is 10 mm diameter. For patient with high surgical risk with technical difficulty. So now coming to the novel therapies regarding the cyst regression. These are the vasopressin antagonists. The mode of action of these vasopressin antagonists, they decreases the cyclic AMP and decrease cyst volume. Currently under trial, but they are used with beneficial effects. Other drugs are somatostatin analogs. Somatostatin acting on the somatostatin receptor that inhibit cyclic AMP. So accumulation not only in the kidney but also in the liver. Octreotide have been developed for clinical use. Octreotide and ranitidine are generally well tolerated by patients self-resolving abdominal cramps and loose stool are common in the first few days following the injections of these medications. mTOR inhibitors, the accumulation of target, the mammalian, what is mTOR? The mammalian target of rapamycin. M for mammalian target of rapamycin inhibitors. The drugs are sirolimus, everolimus, and tacrolimus. These are the mTOR inhibitor that significantly impair the cyst expansion and protect the renal function. Other investigational therapies like SRC inhibitor, bosutinib, AMP activated protein kinase, metformin, and PPA or gamma agonist inhibitors of channel required for chloride secretion and inhibition of the KCA3, tumor necrosis factors, receptor antagonists. So various drugs are under investigation, still not in the FDA approved. When these patients develop the end-stage renal disease, when, then there is no option for conservative therapy. End-stage renal disease, patient either require maintenance hemodialysis or kidney transplantation. So transplantation is the best choice in this patient for end-stage renal disease in patient with an autosomal dominant polycystic kidney or adult polycystic kidney. So there is no difference in patients or graft survival between these autosomal dominant patients or other population. Autosomal dominant polycystic kidney patient and other end-stage renal disease population. Living donor transplantation also a graft survival no different from that of the non-autosomal dominant population. Sometimes these patients usually require the nephrectomy. In case of polycystic kidney, nephrectomy, removal of the kidney usually not indicated, but there are certain indication. When you go for the kidney transplant, pre-transplant nephrectomy is indicated. The indication for pre-transplant nephrectomy include a history of infected cyst, if the cyst is recurrent infected, or frequent bleeding with a hemorrhagic cyst bleeding, or due to in the cyst due to compression, renin-angiotensin mechanism is activated, or due to more erythropoietin hormone secretion, severe hypertension, massive renal enlargement of kidney with extension into the pelvis. So, pre-transplant nephrectomy is required. Hand-assisted laparoscopic nephrectomy is associated with less intraoperative blood loss, less post-operative pain, and after recovery compared with the open nephrectomy. So, if you compare with the open nephrectomy, there are two types of the methods of nephrectomy: laparoscopic nephrectomy and open nephrectomy. So, the complications are less likely in laparoscopic nephrectomy and recovery is quickly as compared to open nephrectomy. So thank you very much. This is all about the cystic disease of the kidney, various cysts. Thank you again.